We all try to do what is right, but there are times when that path is not obvious. This time, weighing the choices presented by ethics in medical care. The doctors are on call tonight.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Go hard! Whoa! Keep pushing.
Just your head.
Pull red handle to open bag.
In today's medical world, real doctors and real patients have to tackle real ethical dilemmas, almost on a daily basis. These are not theoretical discussions presented at lofty educational forums. These are daily questions that need answering every day as people who provide health care interact with people who need it. A 90-year-old demented nursing home patient develops pneumonia, and the family are asking for hospitalization, antibiotics, and consideration of a ventilator or a breathing tube, even when that patient had expressed wishes years earlier, when he was competent mentally, to let nature take its course if such a condition would arise. What should the doctor do? A baby is born prematurely and has a 100% chance of death unless the baby is placed on a ventilator and receives very intensive treatment, or a 50% chance of death or profound impairment with the very best treatment. The parents are asked for permission to treat and they decline. What should the doctor do? How does the doctor address issues when a therapy such as thrombolytic clot-busting drugs may save a life but has a significant chance of doing harm? What does the doctor do when family wants a borderline functioning parent to stop driving and take that freedom away, which is so very important to that parent? When one physician sees care provided by another physician that is less than stellar, when does she or he step in? To practice medicine is to put theoretical ideals and principles into action every day. But what is the code of ethics with which healthcare providers must act? Where did it start? And how did it develop? We invite you at home to call in any and all questions about medical ethics that you might have. The phone number is 1-888-376-6225. Again, 1-888-376-6225. To help us understand more about this always evolving field of medical ethics is Dr. LuAnn Eidsness, professor of medicine at Sanford School of Medicine at USD and chair of the Department of Medicine. LuAnn, thank you for joining us.
Yeah, well, thanks for asking me.
Yeah. Tell us a little bit about yourself. I mean, you're from, where are you from originally?
Sioux Falls originally. And so I was born and raised Sioux Falls and even went to medical school at the University of South Dakota School of Medicine.
Okay.
My interest in ethics started when I worked as a neonatal nurse clinician in the newborn intensive care unit. We had ethical issues daily.
Yeah.
You know, and so your example just really rang true. And that really started my want to learn more about ethics, because they were always not black and white, they were gray.
Yeah.
There wasn't a right and wrong. There was sometimes choices between all not good options.
Yes.
But it was a good experience.
And that, so you were where in your training or where in your experience?
Before med school, I worked as a nurse.
Oh.
And so that was prior to med school. And then when I went through medical school and residency, I worked on my master's in medical ethics through Augustana College.
Oh. So now that you're the chair of the Department of Medicine, a rather lofty spot, how much practice do you do in caring for patients?
You know, half my work life is at the School of Medicine, and half is in a combination of hospice, palliative care, and ethics.
So hospice is, tell us what hospice is.
Hospice, by Medicare definition, is when someone is near the end of life, and Medicare defines that as 6 months or less. And so they're near the end, but the focus is on quality of living, not aggressive curative treatment, because most of the time that's been tried and it's not working, the disease is progressing. So the focus then is on how can a person live until death occurs, and then allow that death to occur naturally. And most people want to be at home for that death to occur.
So it's providing intensive support for the suffering, to relieve suffering, support for the family.
Absolutely.
And to help them, allow them to be at home, if you can.
If you can.
If you can. Not always happens. Now that's hospice. So you do hospice medicine. But you're also in this thing called palliative medicine. Tell me about that.
Palliative medicine is really a similar philosophy, and it's still a team approach. It's very much a team of physicians, nurses, dietitians, social workers, mental health counselors, chaplains, and we work together, again, working with the patient and family to improve quality of life. What's different is that hospice is near the end, and palliative care can be years before someone enters into hospice. And so if a person is diagnosed with a cancer, they may be having attempts for curative, or at least put the cancer in remission. If it's an end-stage heart problem, they still may have very aggressive heart treatment, angiocast, bypass surgery, whatever. So there's a blend of looking at quality of life comfort in addition to aggressive, maybe curative treatment. But it's also focusing on patient and family.
So give me an example of a palliative care case.
Someone who has a new diagnosis of a lung cancer, and it could be an earlier stage lung cancer, and so the goal is to maybe even do surgery, radiation, chemotherapy to put that cancer in remission or slow the growth. And so that can give a person even years of life expectancy. As time passes, the lung cancer may progress, and further treatments don't seem to be beneficial. So then as we're working with patients and family, we talk about, you know, is this the goal you want, to go through yet another course of chemotherapy that is making you so tired you can't visit with the grandkids? Or would you like to, you know, stop the chemotherapy and focus on that quality of life? There was actually a recent study, meaning probably a few years ago, where people who had lung cancer and were in a palliative care mode, not treatment mode, actually lived longer and had better quality of life.
Go figure. We went for comfort and support, and they made it longer. Yeah, I'm amazed at the factors that influence a person's end of life. You know, when you know it's coming, that are so much caring and loving and touching, and not so much all that mechanical stuff. Now you spend a third of your outside the administrative wall doing ethics. What role is that in? How does that play in your life?
Well, I'm medical director of ethics at the hospital, and have been part of the hospital committee since I started there in 1990. And that really gave me a firm foundation for my work in palliative care, because a lot of what we do is deal with the advanced directives, who's going to make decision, what are the goals of care, what are your wishes at end of life. It's interesting because the work we've done in ethics started out more end of life ethics, but now it's transitioned into that gray world of prenatal, you know, diagnosis, pre-genetic counseling and genetic manipulation.
Before anybody's even been pregnant.
Right.
That before pregnancy counseling. That's a tough area. Let me ask you this. I've thought about palliative care, though, in a different way than you described it. And of course, you're steeped in it, and we don't have a palliative team here, so it's different. My perspective, though, was that in our hospitals in the United States, a lot of people have been given full court press, full court press, full court press, even when their prognosis is very poor. The support study in the 10 years ago said we really didn't face the fact that there's a time when people are really, prognosis is extremely poor, it's time to let go, but the doctors don't do it. The nurses don't do it. They stay in the intensive care unit, and that the palliative care team can be called and help people transition out of that. Now, am I wrong?
No, that's very correct. A lot of what we do when we meet with patients and families in the hospital is, what are your goals? What were your goals prior to this? Now that you're in the hospital, in the ICU, where would you like to go? And goals of care can change. You know, going back to the person diagnosed with lung cancer, they may want to have been very aggressive. But as things progress, their goal of care may be toward more keep me comfortable, I want to be with my family. And so it's really, the conversation is so important, because the conversation done at one point in time isn't fixed. It evolves as the person's life evolves.
We could talk a long time about distributive justice. In other words, how much money do we spend on that last 3 months of a person's life, and how so much of that is wasted, and that we could save money for our country. On the other hand, that sounds akin to the pulling of the plug on grandma, and we need to be very careful to make sure that people understand. I think that was a cruel and an inappropriate description, and we should come back to that later, but we have a little bit more here about something else. Any discussion of ethics, especially medical ethics, needs to have a baseline to start with, an official code of ethics that can bring us to that place where we can proceed with the knowledge that what we are doing has been structured so as to ensure the proper treatment of the patient and their relationship with the caregivers.
We live in a society in which we're very fortunate to have a whole series of standards and safeguards. These have evolved over time, and we now have a fairly, what I would call a fairly robust set of standards, codes of ethics. And probably the most interesting and significant component of ethics is that it provides us with a set of rules or set of principles or behaviors that we can operate within. And therefore it's a very comforting kind of discipline. Now, without a set of rules or principles to act within, one would be kind of left astray, and it would be difficult to make any sort of formal decision making. And so the most important part about the autonomy principle is that it guarantees the patient the right to be respected by the physician and any other people. Just as when we go see our lawyer, we don't expect the lawyer to talk about what we visit with the lawyer about. When we talk to our pastor, we invoke the principle of confidentiality. When we visit with our physician, we expect to be treated with a dignity and a certain respect. And all of that is based on this fundamental principle of autonomy. And spinning out of this autonomy principle is the document that every patient signs when they are going through a particular procedure. And that's called the informed consent document. And that's a marvelous document in and of itself, because the two words informed and consent tell you exactly what's going on. The fundamental rule of informed consent is the very first principle of the Nuremberg Code, which was adopted in 1947 following the atrocious Nazi experimentations on Nazi prisoners. And among the 10 or 12 rules or standards of the Nuremberg Code, the first and most stringent and most essential is the principle of informed consent. Medical ethics deals with the entire course of one's life. And we used to say, going all the way from birth through our lifespan and then to the end of life. Now, with our very penetrating analyses of DNA, molecular genetics, molecular biology, we have to adapt that expression to before birth, because now we have this potential to manipulate the early embryo. And so we have then another whole tier of responsibility. How should we treat these embryos? How do you define an embryo? Is it a human being? Will it become a human being? There is no perfect answer. There is no perfect answer. There's no perfect solution. But there is an elaborate process in place that can allow us to sort our way through the thicket of medical ethics and arrive at some very good points.
Let's talk about the principles that Dr. Granholm just outlined. What basic principles, how would you put it?
Mm-hmm. When we talk about the principles of ethics, they're basically four, although I may add a fifth. But we talk about autonomy, beneficence, non-maleficence, and justice. And autonomy is very important because that's respecting the patient for his or her self and what they want.
That's something that the lawyers brought to us in the 40s when they started suing us for not giving informed consent, correct? I mean, that's really came to us.
Well, it really started from the Nazi research that was done that Dr. Granholm was talking about. I think it became a policy in the hospitals probably in the 60s, 70s, and part of that was relating to the rebellious 60s. People, you can't tell me what to do. I need to know so I can make my own decision.
I have a right to self-determination, which is in our Constitution.
Yes.
So, I mean, one could say it does go back to the Constitution of the U.S.
Mm-hmm. And to be autonomous, we have to be able to take the information in, sort it through, and make a rational decision based on rational reasoning. If we can't do that, then our decision-making capacity is impaired in some way.
And a good example of autonomy would be the advanced directives, for example, or that kind of a thing.
Exactly. In fact, advanced directives are our way to respect a person's autonomy. If they get to a point where they can't make decisions for themselves, we turn to their advanced directive.
Right. I don't want to have a feeding tube if I don't know who my family is and I'm stuck in a nursing home and I stop eating and drinking. I don't want to have a feeding tube. I write it down. Then when the time comes, it isn't what the family wants. It's they need to respect my choice.
But that's so hard for family to do because family have a hard time letting go of mom or dad. They don't want them to die.
Right.
And we have to remind them that, but what would mom want?
Yeah. And
would
that
she want to be
supersedes
on this machine?
that supersedes what the kids want, really. What did mom want? What other principles?
Beneficence is to do good, and out of the principle of beneficence does come paternalism. For many years, paternalism, I think, has had a bad name because we focus so much on patient autonomy. But paternalism, in my mind, is a physician being really a compassionate guide. Because as a physician, we know what's the diagnosis, what the treatment, the prognosis. Those are the three things that we do: diagnose, treat, and give a prognosis. And if something isn't going to work, we really shouldn't offer it to a patient as an option. That could be considered paternalism. So really there should be a balance of that respect for autonomy. What does the patient want? And yet the physician having some paternalism to help guide the patient. Right. And I think there should be a balance there.
Okay, so that's beneficence, doing good. What about the next one?
Non-maleficence is to avoid harm, so we don't do anything to intentionally harm a patient. Some people say, well, you do surgery, that causes pain. Well, that's not intentionally harming. That's a result of the surgery, which is to do good. And we do avoid harm by maybe withdrawing treatment that isn't of benefit anymore. We want to avoid harm by providing pain medication so a person doesn't suffer from pain.
Well, I've heard a lecture this week where an ethicist was making the point that beneficence is all well and good, but it's hard to know what is good. It's easier to know what is bad, and that we know better what is good by knowing what is not good. And so the non-maleficence is more of a functional ethics. The thing that always comes in my mind is giving a thrombolytic for a person who's having a new stroke. We know that person who has just the right stroke, and if we can get it that first 3 hours, we can 30% chance bring back flow to the brain and save them from the terrible dementia of the stroke. But there's a 5% chance that you will kill them. So then you could do harm. Would that be a good example?
It really would be. We're, I think, constantly looking at what is happening to the patient, what's our recommended treatments, but what are the risks and benefits, and that's involved in informed consent. What are the benefits if we do this? What are the risks if we do it? But on the flip side, if we don't do it, what are the risks and benefits? And the patient needs to have all that information to decide.
Okay, so what we've hit is autonomy, beneficence, non-maleficence, and
then justice.
And very quickly.
Each person gets what's due to them. And I think it becomes really confusing, because if someone contributes to society, do they deserve more health care? I think many people will side that health care is a basic right in our nation, although there's some who don't think that, which is why the health care reform is such a big issue, and maybe we're not quite getting into health care reform tonight.
Well, we could. But you think about it, if you only have $5 for health care and there's $10 of need, you only have so much money, how do you distribute it? So you try to distribute it fairly, and that's the question of justice. Well, we can go a long time on those things. Many times ethical questions arise at terrible, stressful times of crisis. There's been a car accident, or a parent is stricken with life-threatening medical concerns that may require extreme measures. Physicians and family members have important decisions to make in a short period of time. One option that can help immensely at these moments is when the patient has made an advance directive agreement with their physician.
Dr. Owens, advance directives is something that a lot of us have heard about, but it's hard to keep straight what the specifics are. Could you explain?
Yeah, advance directives a very important thing for all people, not just people that are elderly or getting to the end of their life. And what it does is it allows a person to be specific of what they want to have done if they can't speak for themselves, or if their mental capabilities, they no longer can make those decisions. And it's gone through quite a period of change over the last 10, 15 years. It used to be either you were a no code, or don't intubate, don't do chest compressions, or you were a full code. That's not really what I'm talking about. That's part of it, but it's not the entire story. Say somebody, even things like, would they want a feeding tube if they no longer could eat due to dementia, or would they want invasive procedures done? So it's more than just checking off a box and saying, I want to have everything done or nothing done. And I recommend folks really bring it up with their doctor and go through the specific points. There's a form called a POLST, a Physician Orders for Life Sustaining Treatment, that goes through this in some fair detail, and you can kind of just check off different areas, things like supplemental feeding, artificial hydration, that sort of thing.
So if I want to bring this up to my family doctor on my annual exam, is he going to think there's something, I'm being a little goofy, or is this like a normal thing to talk about?
Matter of fact, you're making for him or her their job easier, because sometimes it's kind of difficult to breach this subject in the clinic, and it's much better to be dealt with during a time of non-stress. It's much better to be dealt with before that person has a life-threatening event.
I'm under the impression that when crisis does hit and a loved one is in the hospital, family members may have differing ideas and sincere different opinions based on what they think the true wishes are.
Right, and in my clinical practice in Redfield, it makes it very easy to go back in the chart and say, on this day, this is what your dad told me wanted, or your mom wanted done and not done. And so, yeah, it's much better to be done not at a crisis time.
Okay, one final word about advance directives and what people should keep top of mind.
It needs to be discussed. Right. It needs something out in the open.
Okay, Doctor, thank you so much for joining us.
Thank you, Matt Owens, for that. I wanted to make a comment, but you know what? We've got a question. He called and said, what is the difference between an advance directive and a living will?
A living will is an advance directive, but it's a type. It's an instructive advance directive. So under the big topic advance directives, it's a person giving their direction to their loved ones or someone they trust of what they would want if they were, yes, in advance. So there's a verbal advance directive. Just talk about it. That's what's so important, is you got to just
talk about it.
Exactly. And that at minimum is what should be done. There's a durable power of attorney for health care where you actually appoint someone to make decisions for you, someone that you trust. And then the living will goes into effect if someone is terminal and can't make decisions for themselves, and they're just listing what they do and don't want at that point. In my mind, the durable power of attorney for healthcare is a much better document because I get to talk to a person, not try and guess on a piece of paper what the person actually would have wanted, but a person who knows and loves the patient.
Right, but you know, it's interesting. So I have 4 children. I would assign my durable power of attorney for this one, the first, second, third, or fourth. I'm not going to tell you which, because that one will do what I want more than the others who are going to be caught up in the emotion of it all. I mean, I'm just saying, for example. But the point is that that person, that durable power of attorney, is not automatically given the power. That durable power of attorney has to do what I would have wanted. There's a lot about that right now, isn't there?
There really is. And I have known people who don't appoint a spouse, for example, because they know the spouse would never withdraw treatment. So they may pick a friend, or they pick a child who they know would honor their wishes, because by law, you have to follow an advance directive. What is stated in that advance directive must be honored by everyone. You know, in reality, I think we all sit at the table and try and get everyone on the same page so that they do respect that. Yep. But the black and white of it, it must be honored.
I had a patient who really had said some things, but it wasn't for sure. Had a terrible stroke. They were struggling with him because no matter what they did, he would end up with aspiration pneumonia. And he would end up with pneumonia and in the hospital and suffering and pain. They'd have to put him on a breathing machine. He was stuck on a breathing machine, and it was really time to let go. And if they knew, they all knew that it would have been the thing to do. But the family was struggling, and they were at each other. And I could see that it was destroying their family. So what we did was we had a lot of powwows and talked about, you know, what would he have wanted? Think about that. Here's a scenario. No one could have described this scenario. What would he have wanted? And they all came together finally, which was joyful for me because I thought I was part of the healing of the family as well as allowing the man to die in a terrible scenario.
Well, you can imagine the tension in that family if they hadn't come up to some resolution after the death of the loved one.
A quickie. My general living will or advance directive is I asked them 3 questions. Well, if you had a cardiac arrest right here and now, would you want CPR? Yes or no? And they'd say yes most of the time. Or if they're 85, 90, sometimes they'll say, let me go. A nice, easy way out. The other options are cancer and, you know, all this. Second one is if you had a stroke and you didn't know who your family was and you couldn't recognize them and it was permanent, would you want to have CPR then? Yes or no? And in that scenario, would you want a feeding tube to be kept alive? Even if we did give you food and water up to your lips, you wouldn't take it. Would you want a feeding tube? I think those are 3 good questions you should chat with your family about. I'm asking you to talk to your family about these issues. What would you want? Now, let me ask you this. What about if a family disagreed with the advance directive of the patient? The patient is going to die no matter what you do, or has lost brain power so that the only people that are left on this earth that speak for that person are right there, and they're saying, do everything. And they're the ones who would sue you if you didn't. The guy is not going to be able to sue you. Will the doctor have the guts to let him go? That's my question.
Depends. That would be a long discussion with patient. But if patient is unable to participate, then it would be with family, identify the decision maker or the power of attorney for the patient. It would take a lot of time to bring everyone around. Physicians also shouldn't be obligated to provide treatment that's not going to help. That's the 5th principle I was referring to initially, the principle of professional integrity. You know, as physicians, we know what will potentially help, and we don't want to harm the patient anymore. If the advance directive is so black and white that the patient is absolutely clear what should happen, as a physician, I really am obligated to honor that. And really, the family aspect can sue, but we're honoring the patient's right, and medically the person has a poor prognosis.
Someone called and said, Dad had a heart attack, the doc wanted to put him on a respirator. The patient didn't want it, so the doctor didn't, and the patient died. and the doctor respected the patient's choice. I think it happens all the time. Well, ethical medical treatment is seldom black and white. Brookings business person John Gustafson developed a genetic heart condition known as hypertrophic cardiomyopathy. This caused him to have a special mechanical heart assist device surgically implanted at the Mayo Clinic called an LVAD to keep his heart working. He had also lost function of his kidneys due to this heart problem. Now he requires dialysis 6 days a week. He is currently traveling to Sioux Falls to receive dialysis. His transportation is provided through services at the Volunteer Service Bank 3 days a week, and friends and family the other 3. It would raise the quality of his life and help him work to improve his condition so that he could be a better candidate for transplant if he could receive dialysis in Brookings. However, the management of the dialysis facility in Brookings is concerned that John is too high of a risk for this, to take on this at this time. And when it was finally concluded, this will have an ethical and practical impact on patients and doctors in the years to come in this community.
Well, the biggest impact of the trip going to Sioux Falls is that I have to go 2 to 2.5 hours it takes to get down there and get set up to get on the machines. And I could save that 2.5 hours a day, and I could use that to help exercise and get myself in better condition. And that's one of the requirements that the transplant people are wanting me to do, is to be stronger so that I can withstand a dual transplant where I'm looking at a kidney and a heart transplant at the same time. I'm in a catch-22 in the aspect that if I can't get myself stronger and better, they're not going to advance me on the transplant list. And so therefore it's very frustrating for me, because I would love to get on with my life and maybe become somebody that is can give back to society again. I had a hard time finding a dialysis unit that would take me, so they called around, and they finally, this is Rochester, called around and finally found me that Sanford would do it. So they came out and they trained Sanford, and Sanford's been doing it since then. So I've been traveling back and forth to Sanford. I've been traveling to Sioux Falls 6 times a week for dialysis. They feel that I am at a high risk, and so therefore they don't want to take on the liability. I've told them I would sign a waiver of liability. The heart issue and the liability is what they're really worried about. You know, like I say, I think we've removed those obstacles. I am somebody that does qualify for treatment. The Sanford people have said that they feel that I'm no more risk than a normal dialysis patient, and so therefore they don't see the risk in having me there, and so I don't know what it is. I really don't.
I will make the comment that I have done what I could and have and will continue to try to find a way for John to have dialysis here. But I also would say that the physician involved here who said no, I did not think did this because of liability issues. I think that physician's choice had to do with not being comfortable that the quality of the care would be good enough here. And I think that physician exercised the right to say, you know, it's like an appendectomy. Should I do this appendectomy on that table in this person's kitchen, or do I say, no, I cannot, I will not, it's too risky, they need to continue to get their care elsewhere. So it's a very difficult ethical conundrum, and no one's right on this. We're just trying to find a way for John to get it here, and it may not occur, but we're trying, and people are doing the right thing and trying to do ethical answers on all sides. I would ask you if you have any comments, LuAnn.
You know, clearly in my heart, and I think all our hearts go out to him, that we want to have all his treatment here so he doesn't have to spend the energy. hard to know because we don't have the other side of the story. And with any ethical dilemma, there's always two sides to listen to and to try and sort out. But certainly I think it's pursuing the reasons why not and see if they can be resolved in any way.
Yeah, I would say that Prairie Lakes was contacted for comment and declined.
Mm-hmm.
Yeah. Well,
physicians have a right to say no if they do believe that it would cause more harm to a patient. And so I don't know if that is part of the situation.
Right. I mean, we look at the autonomy of a patient. Patient has the right to say, I won't have that surgery, mm-hmm. I won't have that treatment. You can't force me to do something. Mm-hmm. I have my own self-direction. Well, physicians have their own self-direction too. Mm-hmm. And I think this physician spent a ton of time trying to research this right, do it in the right way, spent time talking to the physicians in Brookings, and I thought trying to do the right thing. But it's two-sided ethical issue, and we sure would like to help John. Mm-hmm. So I think that there's some issues about artificial feeding and hydration. I'm going to jump to this, change the topic. Mm-hmm. There is a concern that's out there about stopping feeding tubes, or not at the time of the end of a person's life. They stop eating and drinking. There's a worry that we're starving them, or that we're killing them. What is your comment about that?
I think this is probably one of the most frequent concerns that I hear from family. If we stop that tube feeding, we're going to starve mom to death. And so it takes some time to educate patient and family about the appropriate use of artificial nutrition. If someone has some life expectancy but they can't eat because of a stricture in the esophagus or maybe radiation treatment caused some injury, a feeding tube is very appropriate because there's some life expectancy. At end of life, it's the natural process of dying that people lose their appetite. I knew this very personally because when my mother was dying of lung cancer 11 years ago, she wouldn't eat, and I would find her yogurt and watermelon, and I just
stuff it down.
I was almost begging her to eat, and finally she just looked at me and said, "I can't." And then I became doctor and daughter and realized that Mom wasn't going to eat. I shouldn't force her. So personally, I think I learned about it maybe the hard way, but Mom was always teaching. But it's helping families realize that the natural process of dying is one of not having an appetite, to decrease what's eating, because the process of dehydration actually provides comfort, physical comfort at end of life.
Right, the endorphins kick in. If a person stops eating or drinking, and that's where we're at. I've watched this many times because you know that when they're dying, mm-hmm. in the end, this is happening. Instead of keeping them alive for another couple of weeks, dragging it through with IV fluids or feeding tube, you let go, and nature kicks in, and suddenly the pain medicines are no longer needed. Mm-hmm. I think it's a beautiful thing. I mean, that 100 years ago people died comfortably. Nowadays we have too much to do, too much. Mm-hmm. What about the support study versus Osler's study 100 years apart? Have you ever looked at the comparison between how people died in 1804 and 2000?
Well, even 100 years ago, people died at home, and they didn't have all the excess IV fluids or artificial nutrition and hydration, so they didn't have the respiratory distress, because if we give too much fluid, it goes to the lungs and they can't breathe. So I'm not familiar with the particular study you're talking about, but death was natural. Now it's hard to even ask what is a natural death, because we have so many artificial life support, nutrition, meds. It's just hard to get there. I
have to tell you a great story. I'm the head of our hospice in Brookings, and I truly believe that we're all going to die. Let's make it a comfortable way when the time comes. Let's not drag people through excess. But sometimes when you're older, you have some life left in you. And this week, we put a man on a breathing machine in his late 80s that, intubated him, extubated him 3 days later, and his pneumonia is resolved and he stayed alive. I removed a colon cancer from a 96-year-old this week. And doing great. I mean, there's a time to treat, and there's a time to let go. medical research comes with even more opportunities for questions of ethics. There is the balance of needing the data to decide on a new drug or course of treatment with the need to provide the patients, the study participants, with proper care. As physicians, we are called not only to do no harm, but to do good when we can.
Society at large is willing to support a very large research enterprise. Now, ultimately, experimentation oftentimes has to be done with human beings. So we enter then another whole range of ethical analysis with respect to human experimentation. Again, we invoke the principle of informed consent, but the types of experiments that are conducted on large-scale measures are usually what we call randomized clinical trials. Just the assignment of people to experimental groups and control groups is ethically problematic. And whether or not the different treatments have equal efficacy is also ethically problematic. So the whole notion of doing randomized clinical trials with humans, testing different types of therapies, is enormously complex and requires a tremendous amount of ethical analysis. During the course of the randomized clinical trials, any individual within the trial is able to opt out of the experiment. And also, if the data don't look promising, then the researchers can stop the groups. Now, our history in the United States of America with regard to human experimentation is somewhat grim. For example, the Tuskegee study that began in 1930 and really went on for virtually 40 years. And this was a particular study where black men with syphilis were followed over the course of this 40-year period, and they never received any therapeutic agents, even when such therapeutic agents were available. These are all very difficult issues. On the one hand, we have this imperative to do scientific research, and on the other, we have an imperative to treat people with the utmost care and dignity according to the rules and principles and theories of ethics.
LuAnn, tell me about the Tuskegee study a little bit more, and then explain the point he's making about autonomy there.
Well, that study was done on the evolution of syphilis and untreated syphilis, and the men involved were not informed about that at all. And so once again, the importance of informed consent and respecting autonomy in people who are going to be involved in research. They need to know what are the indications for the research, what are the potential problems that can happen, and there's no reimbursement for them. Well, some patients get paid to participate in the studies, but it's really important that they know what's going on, so they're really fully informed of what are the risks of participating in this study. Are they going to get some infection or
right? I mean, and we did at the time we didn't know that treating syphilis would make a difference, and so it was a good study. The problem is they didn't tell them they were doing it. They didn't give informed consent, and we, of course, they do a lot of research with med students and with prisoners.
Very carefully in prison populations, whether it's in hospital for disabled or prisons, they have to be very careful because they really are they doing it voluntarily? Yeah. Are they going to get out a little earlier if you do this risky thing? So it's got to be done right, doesn't it?
We had a call. Living Will Advanced Directive is revising his living will. Attorney says make it general so the doctor will talk to patient's family. In other words, make a general living will instead of so directive, and then encourage the doctor to talk with the family. Have you heard that?
In the living will, it's really virtually impossible to write down every possible scenario that could happen, and so it's almost better to keep it general, but then talk to your loved ones about what that would mean, so that the physician can speak with the loved ones. But then you're back to have a power of attorney. That's a better document. And so if we're going to take home message, we would encourage people to talk about it. Family. You got to talk about it, and then write a durable power of attorney for health care. And it's very important. In South Dakota, we have the Health Care Consent Act, so if someone doesn't have a power of attorney, the decision-making automatically goes to spouse. Right. No spouse, children, then parents, siblings, and then various relatives, and at the very end, it's close friend. And And I was part of that revision, and we really wanted to put domestic partner at the top.
Yeah.
And part of that was I took care of a man who had lived with his girlfriend for, well, more than a girlfriend, significant other domestic partner for 20 years, but they never got married. So when he was in crisis, she officially couldn't make decisions for him because South Dakota doesn't recognize domestic partnerships or
So, and we tried to make that revision, but did it
law.
happen?
We got close friend at the end. Now, that's
good.
Yeah, it's not quite the same, but it works.
So let's talk a little bit about physician-assisted suicide. We don't have it in South Dakota,
no,
but there are several states in this country.
There are 3 states that have physician-assisted suicide. That would be Oregon, Washington, and Montana. And you have to be residents of those states and have a terminal illness. And they usually say 6 months of life left. And then they're evaluated to make sure they're not overwhelmingly depressed, and then they get the prescription from the physician. The patient has to take it themselves. It's illegal in South Dakota.
And what's your take on physician-assisted suicide versus terminal sedation? Let's talk about that.
Well, physician-assisted suicide is when a person, it's respect for autonomy, because it's a person deciding they want to end their life when they're terminal. Terminal sedation or palliative sedation is when a person has intractable pain, and despite all the medications that we have, we can't get pain under control. Some people believe palliative sedation is indicated for even emotional, mental anguish at end of life. But it's literally sedating someone until death occurs.
And are you comfortable with? I know I believe that I don't want to see a person suffer, and I will turn up the pain medicine until they're comfortable. And if they die earlier from this obviously dying process, so be it. I'm comfortable with that.
Mm-hmm.
Are you?
Yeah, I believe with very appropriate pain management, we can get the pain under control. It's very rare that we can't.
Yeah, and for the most part, we don't need to do that, but there's a time. Mm-hmm. Ethics are not just phenomenon between doctors and patients. They touch all of us. We have a societal responsibility to act in an ethical way towards others. Sometimes that might mean using our unique skills or talents to make someone's life a little better because you were there. Shall we gather at the river? And it is well with my soul, and let's get started. Hey.
The Brookings Hospice Singers are a somewhat random group of men who share 2 important passions, a love of music and a strong desire to offer comfort. Hospice singer Richard Smith explains.
You know, I hope it gives some comfort and inspiration to men and women that are in hospice, and knowing why they're in hospice, and really it gives me inspiration too, to be able to see how they react to the songs that we sing, and sometimes they join us in those songs, and that's a happy occasion.
Jerry McCullough, another hospice singer, agrees.
I think when a person is in hospice, sometimes there's a feeling of despair, loneliness, that you're forgotten, and the fact that we come around and sing with them, and then sometimes they sing along with us. I think it gives them and their families encouragement, because we go right into their homes. And I think it gives me a good feeling because I get a chance to do something that help encourage them, encourage their families too, let them know they're not forgotten.
Ryan Kleinjohn, a college student at South Dakota State University, is one of the younger men in this singing group. For him, singing for hospice patients is a way to grow beyond the academic environment and be part of something greater.
It's kind of a way out of ordinary life. It kind of goes and it makes me feel good to go and give something to other people that hopefully will make them feel better. I hope that what we do brings comfort to people as they're going through their times with their families, and I'm just happy that I can give.
That was kind of fun. I enjoyed singing there. And we have our group now is women and men.
Oh, very good.
So we're doing that now, and I can tell you that's the most joyful time. There's a communication that occurs. We have a caller that asked about the benefits of Comfort One, LuAnn.
Comfort One is again recognizing a person's right not to be resuscitated, and the paramedics are obligated by law to resuscitate if they're called to a 911, unless there's a Comfort One. So if there's a Comfort One present, the paramedics, EMS would not resuscitate.
So that's an interesting thing. If I wanted to get a Comfort One bracelet, how would I do that?
You get the Comfort One form from your physician, and that's filled out and signed by the physician. And then if a person is very mobile, we do encourage the bracelet, and it's purchased through the Department of Public Safety. So I think it's about $35.
I think you can, if you Googled Public Health Department, and you could find it there
Probably.
too. Yeah. So there's a take-home message. We got about 30 seconds, I think, somewhere in there. What would that be, LuAnn?
Just repeating that people need to talk about it. Talking about death won't make it happen. But it's such a burden on patients' families when they don't know what mom or dad wanted, or a spouse or child. And so it's really important to have the conversation about what they would want if they can't get better.
Would I want CPR? If I didn't know my family members, would I want a feeding tube to be kept alive?
Continue the ventilator or not.
Right. Issues like that need to be discussed.
Absolutely.
And we've got 30 more seconds. So your experience as the ethicist in our state medical education, what has that been a joy for you?
You know, it really is. You know, the medical students I work with are so hungry for information, as are the residents. And teaching them ethics is fun, because they love to talk about the challenges. You know, when something's right or something wrong, it's a no-brainer. It's either right or wrong. But the ethics is gray, and there's a lot of discussion on both sides of what things should be done.
I mean, it's a real growth time for people.
Absolutely.
When they're going there. We can have very involved discussions concerning how people should interact, what the attitude and demeanor a doctor has towards a patient and what it should be. But in the end, it comes down to something that humankind has known for 1,000 years. In 1988, a physician, Arnold Gold, educator at Columbia University, noted a disturbing trend for medical students and residents. Students were overemphasizing advancing technology while forgetting about the value of a caring bedside manner. Indeed, a patient survey noted that 12% of patients believed their doctor didn't know their name, 20% felt the doctor was rude or condescending, and 47% sensed their doctor was rushed. Dr. Gold wondered why this was happening and if there was a way to train young students in medicine to be more compassionate. How do you teach someone to have empathy and feel another's pain? Thus, the Gold Humanism in Medicine Foundation was begun in order to emphasize the virtue of caring and the value of simple kindness at the bedside. This is not just because it's the right thing to do, but also because it's a very powerful tool in helping patients and families heal as they struggle with any kind of illness. Humanism, by definition, started with the ancient Greeks and ancient Chinese, Indians, Persians, as each group independently, thousands of years ago, described value concepts of compassion and justice. In the late 1400s and early 1500s, the Italian Renaissance brought back Greek teachings, classical humanities, and an ethical philosophy of social science. Hoping to bring all disciplines together, they also studied the Jewish Kabbalah as well as the earliest gospel writings of Christian forefathers. History has it, however, that eventually this wonderful humanism movement clashed with certain religious leaders who declared that love of humanity could not come from human reason alone, but only from the divine. Humanism leaders, in contrast, came to reject any component of faith not supported by scientific proof. Unfortunately, the polarized groups lost sight of the message about caring for one another. I like best the German art historian Erwin Panofsky's definition of humanism, as an attitude of respect for the human dignity, especially between human individuals. He said that humans are intrinsically free and rational, but are limited by fallibility and frailty. We therefore have responsibility for each other to tolerate failings while protecting freedoms. God grant me the wisdom and empathy to feel another's pain, the responsibility to accept frailty while protecting freedom, and the kindness of a good bedside manner. Well, that wraps up our show for this evening. I want to thank my studio guest, Dr. LuAnn Eidsness, Professor of Medicine at the Sanford School of Medicine at USD and Chair of the Department of Medicine, because it would be unethical to do otherwise. And thank you, our viewers, for watching. Your questions and input do make a difference in the world. Until next time, stay healthy out there, people.
Is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.